Hello everyone, and welcome to the SAV's June educational webinar event, Anesthesia for Bronchoscopy. Before we begin, just a few reminders to anyone unfamiliar with the SAV webinars. The audience is in a listen-only mode and is currently muted. Please submit any questions you have throughout the lecture by using your question feature. It's located on your control panel. We will address the questions at the end of the lecture during the Q&A portion. At this time, I will hand it off to Dr. Danish Ahmad, who will be moderating tonight's session. He is the SAB's Education and Program Committee Chair.
Hi all, thank you for joining us and welcome. It is my pleasure today to introduce Dr. Nisnevitch. Dr. Nisnevitch is an assistant professor of medicine, of anesthesiology at Penn State College of Medicine at Hershey Medical Center. She did her anesthesia training at University of Medicine and Dentistry of New Jersey, and further subspecialized in thoracic anesthesiology at Memorial Sloan Kettering. She focuses her time on thoracic anesthesia at Penn State and is involved in not only thoracic anesthesia, but interventional bronchoscopy as well. Dr. Nisnevitch, thank you for coming and joining us.
Hi, thank you for your kind introduction and thank you for having me, especially at this time of the day. Hope there are any people from East Coast, those who are dedicated enough to forgo the dinner time and spend this time in education listening to the lecture. No, just kidding. Because I don't know any anesthesiologist that would do that at 7 o'clock in the morning, at 7 o'clock in the evening to listen to the lecture. Although no, I do know one. My husband is listening. So I will start with my presentation. Hold on, somehow I still see you guys. There we go. With some mandatory slides. Unfortunately, I have nothing to declare today and nothing to disclose. So this slide technically says that I prepared these presentation slides myself, and I have only myself to blame if something goes wrong. Here are the objectives of my presentation today. I will talk a little bit of history, types of anesthesia, all kind of medications and airway management and details used for anesthesia, and then the ventilation for different modes of bronchoscopy. So I'm going to start with history because our subspecialties are kind of related. We share the same founding fathers, so maybe we're brothers and sisters. So that's how it all started. In 1890s, the tools started developing to visualize the airway. And it started mostly in Europe. Alfred Kirstein was the first person recognized as a pioneer of direct laryngoscopy. He was practicing in Berlin, Germany. He was the first one to describe the direct visualization of the vocal cords with an otoscope. And then he was modifying that device to make it more useful. The way it started like many inventions at that time with an accident. So Kirstein just learned from one of his colleagues who was trying to place an esophagus and probably wasn't that skillful with the esophagoscope. So his tool accidentally slipped into the trachea, and the person was surprised with a perfect view of the bronchial bifurcation that was obtained. And to his colleague, it was just a funny story to tell during dinner, but Kirstein took it really with great interest, and he started trying to replicate that and then to develop that a little bit further. So he started to use the esophagoscope, putting it in the esophagus, and then a smaller scope, putting it into the larynx. The main problem was with the lighting. There was no built-in lighting at that time. So he started using the lighting that was used for the urology procedures to visualize the ureters. And his technique was quite successful for the direct laryngoscopy, to the point that he became very well recognized and published on that. And he stated that otoscopy, even though difficult, now it is fully absorbed into the practice, but it still was nerve-wracking and can cause them digestive disturbance in those who are performing it. Despite the success of that otoscopy, Kirsten was aware of a number of problems associated with this method. He was concerned of the extreme extension of the neck needed for a successful placement of the esophagoscope. He was also concerned
Dr. Nisnevitch, are you there?
usually multi-talented, talented in different areas. So Kirsten was a very good painter, and all of a sudden in 1903 he decided to abandon medicine and to pursue the career as a painter and an art historian. He did that until the eruption of the World War I, when he realized that his skills as a physician are much more useful at that time, and he completely abandoned painting and switched back to medicine and never took brushes in his hands again. So this very interesting career in that respect. This is the otoscope that he modified. If you see, if you know what the Miller blades look like, so these blades look very much like Miller blades, and you can see here the positioning that he used for his direct laryngoscopy with the patient sitting up and extreme neck extension. Kirsten was the founder of laryngoscopy, but as the tool had developed further, people decided to go further and further into the bronchial tree. So Gustav Killian was the first one who performed a rigid bronchoscopy and described a rigid bronchoscopy, also performed under the cocaine anesthesia. And he was the first one to remove the pig bone from the right mediastinum bronchus. He was a professor at Mainz and then became a professor in the University of Berlin. And he was actually establishing the subspecialty of laryngology because it did not even exist at those times. Then from Europe, the techniques and subspecialties started spreading very rapidly throughout the world. It reached the United States almost at the same time, and Algernon Coolidge was the first one to perform the successful foreign vital removal in 1898. He was from Mass General Hospital at that time. And later, in early 1900s, Chevalier Jackson developed the tool even further. He devised a lighted laryngoscope and bronchoscope and laryngoscope and several instruments for a removal of the foreign body. So Jackson was the first one to describe the combination of not only visualizing the larynx, but also passing the endotracheal tube into the larynx. So that was kind of a bridge from bronchoscopy to anesthesiology. This is why I was saying that we have the same founding fathers and maybe we're brothers and sisters. So in early 1900s, in 1913, actually that happened the first time. After that, in 1937, Sir Robert McIntosh devised his own laryngoscope, the curved laryngoscope that now we're calling MAC. And he was astonished by what a great view he could achieve by using this curved blade and putting it in the vallecula and lifting it. So now this blade became one of the most commonly used blades throughout the world by all anesthesiologists. I would like to talk a little bit more about Chevalier Jackson for a reason that he was from my negative woods. He was born and raised and worked his entire life in Pennsylvania. He was born in Pittsburgh in a simple family. His father rose livestock in Lancaster County, not far from where I live now. He went to school to what we call now University of Pittsburgh. He received his MD from Jefferson Medical College in Philadelphia, also from Pennsylvania area. The only time he actually left the country to study was to study laryngology in England, because the specialty at that time wasn't that developed in the United States, and there were no professors to teach it. He was growing up as a very small and kind of ill-looking child, so he was bullied tremendously when he was in school. He was bullied to the point that once he was locked in the coal mine by his fellow students, and he spent almost 12 or 24 hours in that coal mine trying to get out. That was so stressful that he got ill and he was unconscious for almost 24 hours at that time. Since then, he developed some lung problems, and later in life, he developed tuberculosis and had to work from home or from a boat that he built and devised himself for a certain period of times during the flares of tuberculosis. He also was a very talented person. In many aspects. First, he was very mechanical. He could devise tools. He was ambidextrous, which helped him with his specialty. He was also very good at painting, drawing, dry point etching. So he actually paid his way through college and through the studies in England by painting china for the companies that made china. He was a very good teacher and very well published. He was a professor at 6 different schools at the same time, which is unheard of in history, except for him. The reason for that being, again, one of that is because the specialty of laryngology wasn't that developed, and he was one of the few founding fathers of laryngology. So, and on top of that, he was an excellent teacher. So whenever he wanted to move from one university to another, the older universities didn't want to let him go completely. So he worked at least part-time in 6 different schools at the same time. His main achievement probably was his campaign to put labels on all poisonous and corrosive substances to prevent ingestion accidents, because he was working mostly with children and had a lot of incidents of lye poisoning, and he saw how much those children suffered, and he actually spent 20 years campaigning just to put the labels on, and he received a lot of resistance from the companies, of course. So he was writing to the Congress, he went to the hearings, and eventually 20 years later in 1927, he finally persevered and the Federal Caustic Poison Act was passed. And that saved countless lives of children and saved them from serious injury. And for that, in 1929, he was actually awarded the Franklin Institute's Elliott Crescent Medal. His work helped reduce risks involved with tracheostomy, because with use of his tools, he was able to remove foreign bodies from the trachea that otherwise would have required a tracheostomy or maybe even caused death of those children. And later on, I'm going to show you the remarkable examples of the foreign bodies that he removed. So based on all these examples from history that I told you about, all these procedures, which were pretty sophisticated and pretty complicated, they were all done under local anesthesia, even though at that time, actually in 1846, William Morton had already introduced ether, and it could have been used for some of the procedures. But most of them were done under local Lidocaine. So because they can be done under local anesthesia, on that note, I can just say goodbye and leave. I can say goodbye and good luck. The reason for good luck is because even though they can be done under local anesthesia, it is very uncomfortable for the patients, and it is much better tolerated if the patients are sedated. So because of that, American College of Chest Physicians, their consensus statement on use of topical anesthesia for bronchoscopy from 2011 states that even though there is an equal safety record of sedation versus no sedation for bronchoscopy, but the patient satisfaction and the tolerance of the procedure is markedly improved by sedation. So sedation is suggested and is recommended for all patients undergoing bronchoscopy unless there is a contraindication. So technically, anybody can do sedation. You don't need an anesthesiologist. Why would we ever need an anesthesiologist to help you with this procedure? Well, first of all, we are there to create the best conditions for the procedure to be successful. We are there to free your hands and concentrate on the procedure rather than concentrating on how well the patient is doing, how well the patient is oxygenating, what is his blood pressure. So you can do your job and don't get distracted. The other reason how I see myself as an anesthesiologist is being a patient's guardian angel. So while you're doing the difficult procedure and exposing the patient to risks of different complications, we are trying to watch over and make sure that the patients are safe. And if something is going wrong, we're there to warn you and all together try to minimize the consequences of the complications. And if the surgeon is always the captain of the ship and the bronchoscopist in that respect is the captain of the bronchoscopy room, I see the anesthesiologist is being a captain of the sinking ship. On that note, I will move a little bit more towards the clinical presentation. So there are several types of bronchoscopies. There's diagnostic flexible bronchoscopy, which is a standard of care for visualizing the airway. There is interventional flexible bronchoscopy like EBUS, navigational bronchoscopy. There is robotic flexible bronchoscopy now, and there is the old school rigid bronchoscopy, which is usually done for diagnosis and treatment of obstruction or some kind of a foreign body removal. So frequently, historically, premedication was used to decrease the undesirable symptoms or to improve the patient's comfort. One of them is the anti-sialagogues like atropine or glycopyrrolate, which have anti-muscarinic effects. And they are used to decrease secretions, and they were used to improve the risk of laryngospasm or bronchospasm. If administered intravenously, their effect is quite fast. The onset is around 1 to 2 minutes, maybe up to 10 minutes. The duration of action, unfortunately, is quite long. It can last anywhere between 2 to 7 hours, especially in those patients who have some kind of a renal impairment, since they are removed by the kidneys. So if the glycopyrrolate is administered to the patients with the uremic symptoms, then their duration of action can be markedly prolonged. And not only the duration of action of the desired effects, but the duration of action of undesired effects, such effects like urinary retention, such effects like constipation, such effects like tachycardia in patients with the prostate issues, in patients with irritable bowel syndrome, in patients with the cardiac problems. These can be detrimental effects, and sometimes they might even require admission to the hospital. So according to the same consensus of chest physicians, they discourage the use of atropine and glycopyrrolate pre-bronchoscopy, because it doesn't seem like they meaningfully improve the lung function. The other medication that is used for premedication is benzodiazepines. Most of the time as anesthesiologists, we use midazolam. Small doses like 4 or 5 micrograms per kilogram is sufficient enough to give some anti-anxiety effects without putting the patients completely to sleep. The sedation is achieved within 3 minutes or so. Maximum effect is in about 15 minutes. The beauty of benzodiazepine is their amnesia effect that can last anywhere from 20 minutes to maybe an hour. The total duration of effect can last up to 2 hours in select patients, but used in the recommended doses, it does not significantly delay awakening, especially if procedure lasts a little bit longer. For very short procedures, it might increase the duration of action and delay awakening. The other good effects from benzodiazepine is that they improve post-op nausea and vomiting and patient satisfaction. Although post-op nausea and vomiting is not that very common after general anesthesia for bronchoscopy procedures, but still can be beneficial in the patients with high risk. Bronchodilators have also been used for pre-medication. If we use it for the patients with true asthma, true asthmatic component, they're probably useful, although I would speculate that the stimulation from the bronchoscope placed in the airway is much stronger than the beta agonist effect of the inhaled albuterol. So maybe better use it post-operatively rather than pre-operatively. And also the use for the patients with just COPD without much of an asthmatic component hasn't been shown to show much benefit. So it's not necessarily recommended for the patients, for all patients with COPD, only for those who might have the asthmatic component. Now let me talk a little bit more about Lidocaine. I have several slides about it, because it's the most commonly used local anesthetic for bronchoscopy now. It is an amide local anesthetic compared to ester type of local anesthetics. It is much better tolerated. It causes much less allergic reactions. It is metabolized by the liver, by the P450 in the liver, and with some liver impairment can have higher risk of toxicity. The signs of toxicity, the first 4 actually, they're mentioned as signs of toxicity, but from my personal opinion, those are more signs of the effects of lidocaine on the nervous system rather than the toxic effects on the nervous system, because almost 100% of our patients whom we administer IV lidocaine on induction, even just 60 milligrams, experience numbness, metallic taste in the mouth, dizziness, and ringing in the ears. If we administer higher doses, then you will see the blurry vision, restlessness, agitation, nervousness, muscle twitches, seizures, and then eventually in the very high doses over 200 milligrams IV, then the hemodynamic collapse can happen and require all different emergency interventions at that time. If the dose, though, is not quite established, So the maximum amount of topical lidocaine used, it still remains an unanswered question. There are several studies quoting completely different doses, anywhere between 2 milligrams per kilogram to 12 milligrams per kilogram. And for example, this last study that I am citing is mentioning 12 milligrams per kilogram as a safe dose. The reason for such a discrepancy, in my opinion, lies in the different methods of administration. So in this particular study, Frey was administering 2% viscous lidocaine for the nasal mucosa, and they nebulized 4% total lidocaine as an oral nebulizer inhalation, and then they used 1% topical lidocaine for additional upper and lower airway as spray-as-you-go technique. So the total dose administered was about 500 milligrams of topical lidocaine, but because the absorption is different from different areas of the airway, all that 5 milligrams did not get absorbed immediately at the same time. So there's no really high peak plasma concentration over 500 micrograms per ml or 600 micrograms per ml. And that way, that can be the reason why they did not see any toxic effects of lidocaine administered at such a high dose. So lidocaine at 2 to 4% applied to mucous membranes have an onset effect of about a minute, and the peak effect anywhere between 2 to 5 minutes. The maximum duration of lidocaine is not that long, especially with the lower concentrations. It is anywhere between 30 to 45 minutes. My guess is maybe 4% can last a little bit longer. That's why we have some warnings in the literature when 4% lidocaine is administered onto the vocal cords. We should take precautions and be careful giving the patient something to eat or drink, because they still might have vocal cords not completely recovered. As I mentioned before, serum concentration more than 5 micrograms per ml can result some nervous system depression. And the half-life of lidocaine is about 90 minutes, so the second dose and the third dose should be administered carefully, and maybe wait a little bit longer until you administer. So one of the more latest studies, well, not very late, but the study that is cited quite a bit, and I guess the more common recommendation comes from this study of mainland. They were comparing different concentrations and different volumes. By different concentrations, I mean 1% lidocaine and 2% lidocaine, and by volumes, I mean 0.2 and 0.3 mLs per kilogram. So they compared 4 different formulations of lidocaine, and they were using them to and evaluating for the sustained cough. And here are their results. So actually, the way they administered the lidocaine was also different from other studies that I cited. That's why it's really hard to compare them all. So they were giving nasal cocaine to anesthetize the nose, and then the patients were lying supine, and the operator, who was blinded, was to the medication that he was administering, was trickling, instilling the lidocaine over a period of 2 to 4 minutes into their nasopharynx while gently pulling the tongue out. So the solution trickles down the tongue and into the vocal cords until the solution, the selected amount of solution was given. And then the 2 experienced bronchoscopies, who were also blinded to the solution that the patient received, they did perform the bronchoscopy 2 minutes after the trickling was finished, and then they were evaluating for sustained cough, and sustained cough was a cough lasting more than 5 seconds. So again, it's really hard to compare these studies because they use different methodologies. But according to their study, the use of 1% lidocaine, 10 to 20 ml, is sufficient enough to decrease the to prevent coughing and sustained coughing, and higher concentrations did not show any meaningful improvement in this in the sustained cough. So their recommendation was to use 1% lidocaine, 0.2 to 0.3 mL per kilograms, to a volume up to 20 milliliters. Then there was another very old study who used, again, a different methodology. They used 6 patients where they had just spray 4% lidocaine LTA, just what we use for intubation, and then they compared that to 9 patients who received 2% lidocaine, 1 milligram per kilogram as IV administration, and they were actually measuring the plasma concentrations, and they drew these graphs which show that the plasma concentration in the endotracheal spray is rising quite slower than the plasma concentration after the intravenous injection, and it does not achieve the toxic levels even at the relatively high amount of local anesthetic administered. So for anesthesia for flexible bronchoscopy, other than lidocaine, other local anesthetics can safely be used. Tetracaine, benzocaine, cocaine has been used, but again, the toxic effects should be considered, especially for benzocaine and tetracaine that can cause methemoglobinemia. Then, as the recommendation states, sedation is recommended. So sedation or general anesthesia can be used. If we do use general anesthesia, then again, there are several options. We can use a total intravenous anesthesia. We can even try to use inhalational anesthesia. The benefits of total intravenous anesthesia is that there is no room pollution, no leakage, it's easy to titrate. Propofol given intravenously decreases the post-op nausea and vomiting. Although the duration of effect might be a little bit longer, especially for longer cases. And it's harder to estimate the depth of anesthesia because we don't see max. So it is better to use the BIS monitor if we're using the total intravenous anesthesia. The inhalational anesthesia has some benefits too. It has bronchodilation effects. It has some anti-inflammatory effects. It is rapid on and rapid emergence. The problem with using inhalational agents for bronchoscopy is, again, difficulty to control anesthetic depth because of the suctioning, because of the possible leaks. Because of the possible leaks and suctioning, there's more room pollution, there's more atmospheric pollution. They can contribute to atmospheric global warming and destruction of the ozone layers. And again, high consumption of the volatile agent because we have to compensate for the leaks with the higher airway flows, and that will cause higher cost of anesthesia. Narcotics are also used as adjuncts to general anesthesia. My personal preference is to use the short-acting agents because during the procedure is very stimulating and we have to use very high dose of narcotics. But after the procedure, it's not really stimulating. So if the narcotic has a longer half-life, like for example, fentanyl or morphine, then the patients will take forever to wake up, which is undesirable. So my preference for the simple bronchoscopy was to use alfentanil. But unfortunately, alfentanil now is hard to procure. Our institution doesn't even have it because we were buying it from Acorn Pharma, and Acorn Pharma went bankrupt. So now the only company that produces alfentanil is Pfizer. So the only other medication that is left, which is short-acting and very reliable, is remifentanil. Unfortunately, it is much more expensive than alfentanil, but it has several desirable effects, like the onset of action is very fast, the duration of action is very predictable. The context-sensitive elimination half-life is only 3 minutes because it is eliminated by ester hydrolysis. It does not depend on any liver function or the kidney function for excretion or metabolism. It is, I think I mentioned already, relatively expensive. And it does cause a little bit more of a muscle rigidity than, let's say, alfentanil does. So that can be another concern doing the bronchoscopy. So we need to compensate and relax muscles with either propofol or, in severe cases, maybe with muscle relaxation. Now, moving on to how do we manage airway for the bronchoscopy? Well, you can do spontaneous respiration without any airway. We can do apneic oxygenation, maybe with high flow nasal cannula, oxygen at 30 to 70 liters per minute. That has been introduced several years ago, and it became very popular because it does decrease the desaturation less than 90%, quite effectively. Then we can use laryngeal mask airway, preferably size 405, just to accommodate for the size of the endobronchial scope. The only LMA that cannot be used is the one that I'm showing on this picture. This is a Supreme LMA because the lumen here is actually elliptical. It's not circular, so it is impossible to pass large-size bronchoscope through it or put the breathing tube through it. Other LMAs can be used safely, but I prefer LMAs with the hard bite block built in, such as Aura or I'm blanking on them right now. So the ones that have hard bite block. If we decide to intubate the patients, we should intubate them with a large size endotracheal tube, size 8 or larger. Because if we use the 6mm EBUS bronchoscope with an 8mm internal diameter endotracheal tube, then the remaining cross-sectional area, this is not exact math, this is more of an estimation of the cross-sectional area, will be equivalent to the cross-sectional area of the 2.5 or 3mm endotracheal tube. This is the size of the tube, 2.5 or 3mm that we use to intubate neonates. So the lumen is quite small, the peak airway pressures will be quite high, and ventilating the patient might be difficult. So our recommendations is to use at least 8.5 endotracheal tube if the EBUS is planned. I think I touched base on that statement already, so I'm going to skip it now. IV fluids. The recommendation is to keep IV fluids to minimum, especially in the patients who have right-sided heart failure, like many chronic pulmonary patients. But unfortunately, it's not always possible when we're doing general anesthesia without muscle relaxation. We have to give a lot of agents, a lot of propofol, a lot of remifentanil to prevent coughing. So we end up with hypotension, and either we're going to start pressors or we give more fluid. So we end up giving maybe at least 800 cc's of fluid IV for a standard procedure lasting for an hour and a half. Anesthesia for rigid bronchoscopy. It is usually general anesthesia. And it is very important for anesthesiologists and the bronchoscopists to be on the same page, to understand what each one of us is doing and to anticipate the next step and to anticipate the possible complications. The teamwork and trust is utmost important. One of the reasons for that is because we're all working in the same space. We're all very close to each other, and sometimes getting in each other's way. And I don't know how many of you work in the teaching institutions, but in our institution, when we're doing bronchoscopy, and especially the rigid bronchoscopy, it looks like this. So here's the person doing the bronchoscopy, here are the supervising attendings, and there are 25 different people observing. And here's the anesthesiologist trying to see what's going on with the patient. So there's also a very unique approach to airway management, because we cannot just put in airway and forget about it. So how can we approach the airway management for rigid bronchoscopy? One of them is the spontaneous respiration, which can be done in children, but it's not necessarily easy to do in adults. Most of the adults will require endotracheal, will require muscle relaxation to perform endotracheal intubation with the bronchoscope safely. Now, with the bronchoscope, we have to either use jet ventilation or use the negative pressure ventilation. And again, how do we administer anesthesia? The only possibility will be total intravenous anesthesia. We cannot use any inhalational agents at this point. The agents that are commonly used for total intravenous anesthesia are propofol, narcotics, remifentanil or alfentanil. Muscle relaxants are necessary. The other adjunct, and that is and the agent that is growing the popularity, is alpha-2 agonist dexmedetomidine. The benefits of dexmedetomidine are it's a very good sedation agent. It's a very good anxiolytic. It does have analgesic properties, unlike propofol. It does have amnestic properties. It does have anti-sialagogue effects, and the very unique respiratory sparing effects. It does not suppress respiration rate. The other thing is it may decrease the post-op cognitive dysfunction caused by majority of our anesthetic agents via the effects on alpha-5 GABA-A receptors, which are highly expressed in the hippocampus, olfactory bulb, and the spinal cord. And they're also has been implicated in the development of post-op cognitive dysfunction. The downside of using dexmedetomidine is the hemodynamic effects, which are bradycardia and hypotension. The onset is a bit slow, so it cannot be used for induction because the loading dose can be given over 10 minutes, and the recovery is also slow. For rigid bronchoscopy, in two different groups, it was shown that the effects are quite comparable, but patients who received dexmedetomidine took a little bit longer to wake up, but had less coughing in the recovery room. Steroids is another controversial topic. They can decrease post-op nausea and vomiting. They can decrease airway edema from instrumentation of the vocal cords. But again, if you compare different studies, most of them are done in patients in the ICU and after the prolonged intubation. So some of the studies show that there's really no benefit of Decadron given 24 hours before the extubations, whether the patient had a long duration intubation or short duration of intubation. It did not increase it did not decrease incidence of post-extubation laryngeal edema requiring reintubation. In the meta-analysis actually showed that it can have some degree of benefit, especially in children, to decrease the post-extubation post-extubation stridor, rather, not reintubation rate. And it was also shown that if the steroids were administered earlier, maybe 48 hours before extubation, it actually did show improvement in the incidence of post-extubation laryngeal edema. The Administration of high dose of steroids actually should be avoided in patients with these malignancies because of the risk of tumor lysis syndrome. So how do we manage the airway during the emergency from rigid bronchoscopy? Most of the institutions that I had worked in, we just exchange the rigid bronchoscope with a laryngeal mask and then reverse the patient and let them wake up. The other strategy, if the patient is not paralyzed and they're on remifentanil drip, then we can just continue high dose of remifentanil until the patient wakes up. And even though they're not breathing, if they're awake, we can slowly withdraw the rigid bronchoscope and just ask the patient to breathe and stop remifentanil at that time. This is not my favorite technique, but some institutions had been describing that in the literature. So let's move a little bit to when do we need a captain of the sinking ship. The complications of rigid bronchoscopy, which you're all very well aware of. I'm not going to talk about them. The reason why I'm listing them here is because to underline the need for the teamwork and the anesthesiologist being aware of these possible complications, because most of the time we're the first ones to notice these complications and to alert you that they're happening. I don't know how many of you are using cryoablation, because in our institution, the spray cryoablation with liquid nitrogen has been abandoned to my delight. But even if we use, let's say, the topical cryoablation or topical laser, we should be aware of the structures that are behind the area that we are using the thermal treatment of, because if the short bursts are used, there is really not much danger. But if we use the coagulation or freezing for a longer period of time, we should be aware that there are coronary arteries here, that there is vagus nerve in here, that can also, that the temperature can be projected onto these structures and cause coronary spasm or injuries to the vagus nerve, bradycardia, and ischemia. Laser. The neodymium yttrium aluminum garnet laser, Nd:YAG laser, can penetrate tissue more deeply than the CO2 laser. So my earlier slide applies to this statement also. It is used more for coagulation of the vascular tumors, but it is also more frequently reflected and can cause delayed airway edema, which can be noted later when the patient is already extubated. And from anesthesia standpoint, we all have to be very diligent of keeping the FiO2 low, less than 40% if possible, and avoid any potentially combustible substances in the airway. Avoid using the nitrous oxide, for example. When endobronchial fire happens, the first thing to do, actually all these things should be done at the same time. And I know some people say first you just pull out the endotracheal tube or whatever is burning. But in my opinion, first you have to stop ventilation, because if the ventilation is still continuing and you're pulling out the endotracheal tube, you're just pulling out the torch. So anesthesiologists should be paying attention, and we both should be doing things at the same time. So I would be stopping the ventilation and turning off the oxygen flow as you're flooding the field and pulling out the endotracheal tube. That again underscores the necessity for attention and the teamwork. If the patients have stents, it is very important not to manipulate the airway blindly. So it all has to be done under direct vision. So no endotracheal tube should be placed blindly, only with a fiber optic scope. And the anesthesia colleagues should be aware of that. If you don't warn them, sometimes maybe they wouldn't know. So communication, communication, communication. Ventilation for rigid bronchoscopy. It can be done under spontaneous ventilation. Again, I mentioned it's mostly done for children that way. It can be done under apneic oxygenation and periodically insufflating oxygen while you're giving the patient a break. It can be done through a ventilating bronchoscope connected to the anesthesia machine. Negative pressure external ventilation system, but I will not talk too much about it because I don't have much experience with it. And then, of course, jet ventilation. This is the most commonly used technique in all the institutions that I had worked in. This is what the negative pressure ventilator looks like. It's like a carcass that creates negative pressure and opens up the chest. This is what the jet ventilation looks like. Pretty much exactly the same thing. So they can be handheld operated like this device, which are a bit obsolete now, but we still have them to use just in case the mechanical ones don't provide sufficient oxygenation if the patient has significant resistance of the chest wall. These are manually, the lever here is manually squeezed at a rate that is comfortable for the operator, 10 to 14 on average. It can be giving 100% FiO2. It can be used with a blender to use different FiO2. It is connected to the direct wall oxygen that delivers 50 pounds per square inch, 50 psi. So the 1 psi equals 70 centimeters of water. So 50 psi would be equivalent to 3,500 centimeters of water. That's why we need a pressure regulator over here to decrease the peak pressures to below 35 centimeters of water to provide the safe ventilation to the airways. The complications of jet ventilations or hypercapnia because the CO2 is not adequately removed. Hypertension if the CO2 is retained and the patients become hypercapnic and acidotic. Hypotension in the extreme cases. Hypoxemia if we're not delivering adequate oxygenation all the way to the bronchioli. Bronchospasm if the patients are not deep enough. Pneumothorax, pneumomediastinum are the most feared and the most concerning complications of jet ventilation. And if there is an injury to some kind of a vessel as you're operating, that can cause air embolism into the vascular system and cardiovascular collapse. We started using the monsoon jet ventilator, which is a high frequency jet ventilator. It can deliver respiratory rate anywhere from 30 to 300 breaths per minute. The higher respiratory rate actually provides a quiet surgical field, which is a great advantage when you're doing some precise procedures that require no movement. It also has advantage because of the very low pressure in the airway. It can be safely used for all kinds of bronchopleural, esophageal, or other kinds of fistulas. So this is what it looks like, the machine that we use. The main things to set up is the driving pressure, the respiratory rate, the FiO2. It can deliver different I/E ratios by selecting the inspiratory time percentage. It can also deliver additional humidity if the case lasts for a longer period of time. The difference between the high frequency jet and the conventional conventional mechanical ventilation is drastic. In the conventional mechanical ventilation, we're delivering the tidal volume that is higher than the physiologic dead space. During the high flow, we are delivering tidal volumes that is so low that it is much smaller than anatomic dead space, and it is delivered at a very high frequency. So it is a time-cycled, pressure-limited, and most importantly, open ventilation system. So if the chest wall compliance decreases, then we deliver less oxygen into the peripheral airways. So the oxygenation is going to be worse. And it will markedly decrease the minute ventilation. then the driving pressure is much more important for CO2 elimination than actual respiratory frequency. The CO2 removal and oxygenation are not coupled, but they happen at the same time. They're not happening sequentially, and they do not depend on inflation or deflation of the lung. Frequency-dependent PEEP is also present during the jet ventilation. But even though the PEEP is present, the mean airway pressures and peak airway pressures are much lower than during the conventional ventilation. But unfortunately, I already mentioned that this has to be an open ventilation system. If the outflow, the egress of air is closed, if there's some kind of obstruction, then the peak pressures can build drastically and cause the pneumothorax. And this is how the gas exchange happens during the jet ventilation. So initially, the turbulent flows just pushes the oxygen in, and the existing gases around it to the to the proximal areas of the airway. Then the turbulent flow changes into a laminar flow, and the Taylor dispersion helps the high velocity central gases to the margins of the airway. And there is also pendulum effect, where some alveoli have higher compliance and they fill in faster than the ones that have lower compliance and fill slower. So there's collateral ventilation that allows gas exchange between the two. And there's also the cardiogenic mixing that helps with gas exchange. So one more time, these are the main differences between the conventional ventilation and jet ventilation, where in the conventional ventilation, dead space is very relevant and the airway sealing is mandatory. Unlike in jet ventilation, dead space is completely irrelevant and airway sealing is absolutely contraindicated. And the gas flow for the conventional ventilation is bidirectional and sequential, inspiration and expiration. With the jet, it is simultaneous. It only goes in one direction. It is fast and coaxial. That's a quick mention of the robotic bronchoscopy here. I don't know how many of you do that, but there are several anesthesia difficulties implicated in this procedure. Again, this reminds me of the same picture for the rigid bronchoscope, so there's really no room for anesthesiologists in here. The patients have to be intubated with a large size endotracheal tube. The patients have to be paralyzed to make sure that they're not moving, that they're not coughing. The endotracheal tube should be cut to a shorter length to align all this robotic arms. And there are leaks associated with the bronchodapters there that we have to counteract. We have to use lead. The main thing is the ventilator settings. The recommendation is to use the 10 of PEEP and to use the recruitment maneuver. This recommendation is based on the VESPA study, the ventilatory strategy to prevent atelectasis during bronchoscopy under general anesthesia. The study was done at MD Anderson Cancer Center in Texas. Unfortunately, they were not comparing apples to apples. They were kind of comparing apples to oranges, because they compared patients with paralyzed patients with LMA and the paralyzed patients with endotracheal tube and 10 of PEEP. LMA had 0 PEEP. So, of course, first of all, LMA does not create enough seal. There's always a leak. And even if we want to give PEEP, it's hard to give PEEP. So there's much more chance of developing atelectasis in that case. But despite anything, 10 of PEEP with the recruitment maneuver has shown that it drastically decreased the incidence of atelectasis, and atelectasis can decrease the possibility of radial scope to see the tumors very well. So this is the current recommendation. And in summary, again, anesthesiologists need to stay up to date. Effective communication and teamwork is of utmost importance, and we all have to be aware of possible side effects, not only of bronchoscopy, but side effects of anesthesia. And that will hopefully improve patients' outcomes. And even with all the advancements of modern technology that I've mentioned earlier, I dare you to try removing these foreign bodies that were in the collection from Chevalier Jackson. And that concludes my lecture. It was exactly 1 hour.
Thank you, Dr. Nisnevitch. That was an excellent lecture, starting all the way from Dr. Kernstein to Dr. Jackson to robotic bronchoscopy. That was really the full breadth of anesthesia, and I know we all enjoyed it. I just wanted to remind the audience, if you guys have any specific questions, feel free to put that in the question box and I'll get it to Dr. Nisnevitch. I wanted to touch base with you regarding the recruitment maneuvers you mentioned in the VESPA study. In your practice, how often is that being directed by the bronchoscopist? What are the scenarios when you're seeing those recruitment maneuvers?
I don't have the certain exact intervals at which we're doing them. I try to do a recruitment maneuver every time we have a disconnect in the airway, which happens relatively often because we're switching from one bronchodapter to the other bronchodapter, then they're taking out the scope, there's a leak, then they're placing the scope, there's a leak. So I try to do them relatively frequently. I don't do them aggressively. I just put the patients on the higher tidal volumes on the vent, give 5-6 breaths with the higher tidal volumes, and call it a day that way.
Great, great. And I did have a question about jet ventilation. So I think the most important thing that you mentioned in this talk was the communication that has to be present between the pulmonologist and the anesthesiologist, the bronchoscopist and the anesthesiologist when we're doing this very highly complex airway cases. What should be the initial conversation be before the rigid bronchoscope, before the patients were placed under general anesthesia? Should we be talking about can the patient even tolerate jet ventilation? What should be the backups if patient is failing jet ventilation? What do you recommend how would you want the pulmonologist to approach you in those cases?
I think everything you mentioned is a very relevant point. I usually ask first, what are we doing? What are we trying to do? What interventions are you going to do? What are we trying to achieve? And then is the patient optimized enough to tolerate this procedure? If the patient's habitus can cause some kind of a problem, is the patient going to be a difficult intubation? Is the patient so big that the rigidity of the chest wall is so high that maybe our jet ventilation might not be adequate enough? If the patient doesn't have any pulmonary reserve, what is our backup plan? If the jet ventilation doesn't work, we will have to re-intubate the patient and ventilate them periodically. So I think every concerning point should be discussed on the shore rather than in the middle of the ocean.
That's a very good image right there. And the last question I had was with your hand jet ventilation. So, with the monsoon jet ventilation, we have different maneuvers that we can perform when patients are not oxygenating as well as we would want. With the hand jet ventilation, what are the options available? You mentioned that the respiratory rate is in the 14 to 15 range or 10 to 14 range, and your driving pressure is pretty much set. Are there any specific scenarios you would troubleshoot when patients are not oxygenating optimally with the hand jet?
Well, a hand jet is actually more effective in delivering oxygen to the lungs because it's easier to regulate the I to E ratio. So you can give higher inspiratory time. You are delivering higher peak airway, higher pressures, though it's like anywhere around 30 to 35. We rarely deliver anything less than that with the handheld. The main thing that I always look at, because there's really no feedback neither from high frequency jet, nor from health head jet ventilator. There is no feedback. We don't know how much is actually getting to the patient. So the only things, two things that we can actually observe is the chest rise and recoil and the saturation of oxygen. We cannot monitor CO2, and we cannot monitor the peak pressures at the distal airways. So if I don't see the recoil, that is concerning. If I don't see chest rise, it is concerning. That means that our jet is directed in the wrong direction, or the patient had already developed pneumothorax. That's why there is no recoil, or the patient is not paralyzed anymore and the chest rigidity is too high, or the patient is too light and he's fighting the vent. So these are the differential diagnoses that come up into my mind when this scenario happens.
That's great. I think that was, I think that's some of the things that I think about as well. Well, I wanted to take this time to thank you for being so generous with your time and sharing your experience with us. I know I learned a lot, and I'm sure our audience likewise did. Thank you so much, Dr. Nisnevitch.
Thank you for having me, and have a good night.
Take care.
Bye.